One of the most difficult tasks is that when somebody in the family suspects himself to be suffering from COVID-19 infection, or somebody is already confirmed with a COVID-19 infection. Obviously, this entails a lot of anxiety among the family members and personal anxiety for the person who may not be so much sick at that moment. So it is very important that the general public is very well familiar with all the early symptoms of a COVID-19 infection. And once you have decided to get a PCR test for COVID-19, it is important that you should also get a blood CP and a C-reactive protein testing. This is important because sometimes there is a delay in the coming of the results of COVID-19, and if we have already ordered C-reactive protein and blood CP, we would be in a position to understand the extent of the abnormalities which are occurring and possibly some hint of the stage of the disease in which we have. Because one of the big problems is sometimes that the patient cannot accurately date his disease, whether his disease is on the 5th day, is it the 10th day, or is it already about 15th day or something like that. One of the good markers is that if you are doing certain additional tests along with it, you will get the thing. In third world countries where people cannot be that rich, so I have just recommended the CP and the CRP. Otherwise, the battery of tests is much bigger. People do ferritin, they do LDH, D-dimer, even blood grouping, cross-matching, and even some organizations do all the testings for including hepatitis A, B, C, HIV, and such type of testing. One other thing which is sometimes useful and which will not cost too much money is that if you are already affording the PCR test and the C-reactive protein and the blood CP test, it is sometimes better to get a liver function and the renal function test, that in case you are one of those in which the treatment has to be started quite quickly, we at least know that how your renal function and liver function is and what type of drugs you will be able to tolerate. There are adequate guidelines and very updated guidelines which are available in different countries. One of the very famous guidelines is the CDC guidelines for patient treatment. These are quite comprehensive, and they are also available in abbreviated formats on the CDC website. Then you see there is also guidance like the NICE guidance from the UK, National Institute of Clinical Excellence. There is also WHO guidelines. WHO guidelines are quite detailed when it regards to things like masks, sanitizers, and some of the other interventions. Technically, however, we give considerable weight to the CDC guidelines of USA, and also the experience of the doctors locally over a period of time, of which there has been sufficient experience in last 1.5 years. Overall, the doctors who are in the forefront, they report that out of the people who really need to get oxygen and are admitted to hospitals, about 3/4 of them, they walk out of the hospital in a rather better state. There is a definite death rate, and this death rate is not trivial. This death rate is mostly observed in people who are older, who have diabetes, blood pressure, people who are fat, people who have got immunological deficiencies of some other types or chronically debilitated, people with ischemic heart disease, and other types of organ dysfunctions. And also it has been observed that the people with some types of mental retardations of certain types also seem to be more prone to get COVID-19. The list is actually long. Early in the COVID, there was this controversy about masks. Anyhow, the proper types of masks is quite an issue, because the facial features of various races is somewhat different, and the one size fit all mask is not really working that well. The masks tend to be rather good in the current designs, tend to be rather good in over the upper part of the mask, that is near the nose, where they have got some strips to adhere it to the face. But they seem not to be that good when they are dealing with the lower part of the face. Updated mask designs which are effective for the purpose they are, and the main purpose of the mask is basically to prevent in a community setting that the people should not get infected by a single cough of somebody or macro droplets and heavily laden with virus something in just one go. That's the main thing of the mask, although there are masks which are specifically designed to filter out the large proportion of the viruses. They have this ability, they are sophisticated, they are difficult to wear, and they are mostly used in the hospital critical setting, and more so in the past than now. Then there is a lot of tendency of using sanitizers, washing hands, which is useful in every respiratory disease. Although sanitizers are preferred by many people, but probably washing hands thoroughly is quite good, actually, and that has been the age-long practice, because we are never sure in third world countries that we have got standardized sanitizers, whether they work or not, and some of these sanitizers and so on are not regulated by the same criteria as the drugs are regulated, and that's why we cannot be very sure. It's better to wash the hands once or twice long washing of hands. Separate rooms, yes, for the patient with the COVID, very nice. Separate bathrooms is a bit important, because there are patients in which the COVID virus has been found to be in the stools for even up to 45 days, and there are instances in which the COVID doesn't tend to clear from the body and the person is still infective after several weeks. So it is safe that the segregation which patient has enforced on himself should continue for a bit longer time than 2 weeks or 3 weeks. It's better. One other issue is the crucial issue of when to start giving medicines like steroids, like remdesivir or baricitinib, or some of the other medications which are there, blood thinners and so on. There is general agreement that if you feel that the oxygenation level is going down by, let's say, pulse oximetry, and that is the time to start the intervention, and you use the oxygen and you also use the steroids. So far, dexamethasone has attained most popularity, although other steroids theoretically should also be useful, including the bolus doses which are used in certain other settings. There has been a lot of study and a lot of discussions about the role of tocilizumab, the role of remdesivir, the role of baricitinib, and there are certain other monoclonals and certain Janus kinase inhibitors which have been tried. One of the problems with COVID-19 is that unlike, let's say, quinine for malaria or artemisinin for malaria or things like that, we don't really have so far a wonder drug for COVID-19. What we have is a combination of interventions like blood thinning, like oxygenation, like steroids in certain people, and better interventions, including these anti-inflammatory drugs which have been mostly part of rheumatology before, because the damage to the body is mostly done by the immune response to the virus, not by the virus itself so far as we know from the studies, although this aspect is still under study, and that how much damage the virus can do directly. And the assurance of these drugs being available cheaply is of much problem in the world, especially in the third world. There have been experimentation with 5-6 other drugs. In the developing world, ivermectin, a worm drug, has been used very extensively because it was always available in the human dosage, unlike in USA where people are seem not to have an access to the human preparation and seemingly going towards the preparation made for animals and suffering the side effects. There are few studies going on in the West to confirm whether ivermectin works or not. There have been some studies to see the utility of combination of azithromycin and chloroquine, and as far as the erythromycin is concerned, that appeared not to cause that much harm, in the sense that infection was not always the main thing in COVID patients in the early stages of the disease. But sometimes in the late stage of the disease, it is a main consideration, and antibiotics have to be given and proved to be useful. Chloroquine has not found much favor in the Western world, and even in the developing countries, I think its use is falling considerably, as steroids and drugs like Claxane, the anti-clotters, become the mainstay. Outcome, there has been very detailed data, and experienced people can spot the kind of patients who will get deteriorated, will need ventilator in the course of time, and even which are not going to make it as the units get experienced. In the developing countries, it's a tradition that the moment somebody gets into an intensive care unit, most likely he will be handled initially by an anesthetist. So anesthetists are playing a major role in the management of the seriously ill COVID-19 patients requiring ventilation in most of the world. We have limited role for ECMO machines. We have role for certain other intervention. Patient might need other things during the stay. People sometimes need dialysis, as the renal function can go down sometimes. He can suffer from a variety of other problems. One of the most troublesome situation arises when the platelets fall considerably low. Now, this requires the services of very experienced clinicians and hematologists to really assess that what should be done, because that is a bad thing, and that is one of the things which requires more expert advice. Obviously, because respiratory distress is one of the main issues, and loss of oxygenation and the clotting and so on. Therefore, pulmonologists are at the forefront of the management, so are the internal medicine physicians. A COVID patient can present in other ways also, because disease seems to have a tendency towards certain forms of clottings. So it is quite possible that somebody might present with a myocardial infarction or something which has got some indirect link with the COVID-19, or might present even with a stroke or something like that. But generally it is a respiratory thing which we see most often. One of the features by which you feel, it's not that the patient feels himself better as he recovers, is that he notices that his oxygen level is improving day by day when he is recovering, and he also feels less aches and that type of thing. And if you examine the blood system, you'll find out that the C-reactive protein is coming down, and the platelet counts are also recovering, and they're going up, and that type of picture, and you feel that probably the worst is over, although you keep an eye on the patient. Vast majority of patients will obviously recover, and very small percentage among the young will get serious enough to get admitted. However, this is not the case in the older person. One of the things one should be wary of is trying to deal a COVID patient in one's own home, especially when he is a hypertensive with blood pressure, he is a sugar patient, or he is debilitated, and especially if he is an old patient, because the mortality rate is very high, and this is not the kind of patient that you should treat at home without the help of an experienced doctor or an experienced nurse from the very beginning, because that spells disaster. Because the oxygen level is the triggering point of starting more intensive therapy, it is very important that the public is well aware of the way in which it is measured. Oxygen saturation is measured by pulse oximetry. It should be remembered that a proper reading of pulse oximetry means that your hand should not be very cold, it should be somewhat warm, and not recently washed or something. And the reading which is to be recorded is the one which gives the highest reading, whether it is a thumb, the index finger, or big finger, or whatever finger. Theoretically and practically also, it is possible to record oxygen saturation from even the toes and the ear, but usually the fingers are preferred. Ears are sometimes preferred in children, and there are special electrodes which stick to the lobule of the ear and measure it, and they can be accurate sometimes, usually, depending on the make of the thing. One other important thing is that one should not just see the oxygen saturation. One should also observe that what is the breathing rate per minute to achieve that oxygenation. And the second thing one should observe also is the heart rate at which this occurs, because it is sometimes possible to improve your oxygenation by breathing a little more, and it is also possible that by increasing the heart rate the oxygenation might improve a little bit. However, a very good way of testing whether sufficient oxygenation is occurring or not is to ask the patient to walk, if he can walk, for about 1 or 2 minutes, then wait for about 10 seconds, and then start taking the pulse oximetry reading, the best pulse oximetry reading on 1 or 2 fingers. And if that reading just after walking is low, whereas while sitting it is normal, let's say while sitting it is 95, and when the person is walking for 2-3 minutes and after resting for, let's say, 5-10 seconds, you observe that his oxygen saturation is 91 or 92 or 93 or something like that, that means that in fact the time has come to consider interventions, because oxygenation which falls on a little bit of movement or exercise, mild, is basically has the same significance as somebody who is having low oxygen at rest. However, before you apply this finding, you must be a bit careful, because there are certain elderly people who, even in a good state of health, tend to get a lower oxygen level, even up to 93, 92, 94 when they walk. So it is always better if you know their previous oxygen level while walking. Next issue is basically the early problem which arose was that obviously when people were distressed, the initial response used to be that they should be nebulized with some beta stimulant or certain other medicines to improve the airways. But later on it was found that that's in many cases that although it will be helpful in certain patients, but you have to be very, very careful, because the aerosols which are produced by these types of things are very ideal for making the doctors sick and the rest of the household sick. So using aerosols too much in the presence of others without the protection or adequate ventilation and without any necessity may not bring that good a result. However, there have been certain observational studies where inhaled steroid seems to confer some additional protection and better prognosis in COVID, because what was actually thought was that people who have got chronic respiratory issues from before and who take these types of inhalers with steroids and beta stimulants would have much worse outcome, and it was seen that in some cases it's not much worse outcome, and they found out that those who were using inhaled steroids seemed to have some additional protection, which is not surprising, although these findings have to be replicated in much larger trials. I think that we should be grateful to the researchers, especially in Italy and the United Kingdom, that they did some valuable work very early on, and they did proper systematic postmortems on the people and studied the link between the clotting and the aggravation of the persons, which led to a new protocol involving the anti-clotters in the regime. We should also be thankful to the systematic study in the United Kingdom, which elucidated the positive role of the dexamethasone in the various trials. I must say that when the COVID-19 entered the whole world, and especially first in China, it appears that a lot of very different and disparate agents were tried in China. This is seen from the literature coming out of China. And by the time this reached the rest of the world, it appears that the Chinese had done quite a considerable amount of work already on this virus, and they had tried a lot of agents with very variable and inconsistent success. And early on, there were certain considerations that these people might be extremely infectious, and there were cases in Singapore where somebody went to a church and he got infected, whereas there was nobody there except one positive patient in the morning. This type of transfer through articles somatic transfer in the earlier data variants did not constitute more than 1 in 1,000 of the patients who get COVID-19. We cannot say the same for the future variants which become more infective, but that appears not to be the main route of transmission. Now the question is the distance between the people. Often quoted is 6 feet, but probably if you want to count for the sneeze and violent cough, and certain people they speak very loudly and they've got very big mouths and so on, I think that a safe distance would be about 9 feet and not 6 feet. Although politicians have tried to reduce this distance to even 3 feet or something like that, so that the pubs can function and so on, and that is basically not part of science. It might be the part of economics in disaster, not a part of science. This also needs to be emphasized. COVID-19 vaccination, there is considerable amount of literature comparing the various vaccines. And as I mentioned before in the other part, that a large part of the world has taken the Pfizer and vaccine, and a large part has taken the Sputnik, and the Chinese vaccine probably is the most frequently given in the world these days. And they are of various types. Some using adenovirus, some messenger RNA, some the dead organisms or weakened organisms, the traditional approach. And this subject has been discussed, and there are a lot of references to it, and we will not discuss that again. With this, I think that I should end this small presentation. It's not a specialist presentation concerning the various exact and detailed interventions. And again, I would say that people should consult frequently the CDC website, the NICE website, the WHO website, which contains considerable information. The WHO website has got some videos also, and in this respect, although the giant has woken up a bit late, I must say, but it is doing a better job these days, despite the political nature of the structure of the World Health Organization. With this, thank you very much, and I hope that you will try to avoid COVID-19, and you will not go to the various rallies, and you will also emphasize to the local authorities that they should not be opening educational institutions unless a substantial amount of students have been vaccinated, and that there is very adequate ventilation available in the classrooms, and there is a system to enforce discipline. Thank you very much.